everyone. Hope you can hear me. It's 7 o'clock, so we know lots of people will continue to join us, but I'll say welcome to everybody who's here at the moment. So thank you for joining this joint Derbyshire Education Network session and also First 5 Early Career GPs. Really nice of you to come on a Wednesday night. I'm sure you've all had lots of busy days, but we're very lucky to have Carlos come to join us, who is a hand surgeon from Derby, and he's coming to cover common hand conditions in primary care. So such a useful topic. I'm Elise. I hope quite a few of you will have seen me before in the DEN sessions. I am a GP at Crouch Medical Practice, and I also do these education sessions for DEN and for First 5. Please do at the end, if you don't mind, fill in the feedback, because then you will get a lovely certificate which you can use for your e-portfolio. And the other thing about the feedback is we definitely do read it. So if you suggest any education topics that you want, I write these all down, and I'm working my way through and trying to make sure that I cover them. So your feedback is actually really, really important. So I would be very grateful. First off, I'm going to hand over to you, Benicia, if that's okay. Let's see if you are there.
Hello.
Benicia's sponsoring us tonight from your team. So yeah, if you don't mind having a chat with us and telling us about that, that'd be lovely. Thank you.
Brilliant. Thank you so much for having me, first of all. So my name is Benicia. I'm an account executive from Chiesi, and I look after the Foster range in the Derbyshire area. So I'm just going to have a little chat to you guys sort of over the next 10 minutes or so just about our Foster range, the benefits of the Foster range, and in particular I'm going to be focusing on the Foster Nexthaler, which is our dry powder inhaler, and we'll also be touching on some sustainability work Chiesi's been doing in terms of bringing out an environmentally friendly propellant. So the Foster range is licensed in the regular treatment of asthma in adults where a combination inhaler is appropriate. So if they're stepping up from something like a brown inhaler, Clenor, or they're stepping across, if they're not adequately controlled in another ICS labber. And it is the only extra fine formulation ICS labber that's available in 2 different devices and different strengths. And that is really important to note with the Foster Nexthaler, so the dry powder inhaler, it is actually the only extra fine dry powder inhaler. So we'll touch on why that's important in a second. So obviously I know there's a lot of pressure on you guys in terms of looking at blue inhaler overuse, SABA overuse, things like having correct things in place and the correct action plan. So if you look at something like the National Review of Asthma Deaths, it was done in 2014, but things unfortunately haven't changed very much since then. And a lot of people will still die from an asthma attack. 3 people a day actually still die from an asthma attack. And in the National Review of Asthma Deaths actually looked at some of the reasons behind that, and they found that SABA overuse was a major reason. Now, not only is it sort of poor asthma control, it's also like your DES and your IIF, those of you that are familiar with that are looking to tackle some of this blue inhaler overuse. But I just really wanted to mention it at the start because it just shows how important it is to get that asthma control right and get that patient onto a right inhaler. And we really, really stress here at Chiesi that it's not just about using dry powder inhalers, it's about using the right device for the right patient. So whether you want to use it in an MDI or a dry powder, we have both devices there available for you. I won't go into this too much because I know many of you will already be really familiar with this, but it's just showing you the type of patient we use it in. So someone that's using the blue inhaler more than sort of 3 times a week will be stepped up onto something like the Foster. But like I said, I won't go into that too much because I know you're already aware of that. So with the Foster range then, the dry powder inhaler, so the Foster Nexthaler, is the only extra fine formulation ICS labber. It has formoterol and it allows it to be used in a MART regime, so that's a maintenance and reliever therapy regime, and that's because of that formoterol that works within 1 to 3 minutes. MART is really, really important because, it can give you that relief really quickly, but not only that, it can stop that overuse on the blue inhaler because they're getting that extra steroid in early on, they're more likely to reduce how symptomatic they feel as time goes on. So with the Foster range then, you can use it in 100/6. You can use it once in the morning, once in the evening, and up to 6 extra times through the day. So every time that patient feels like, you know, I want to use a blue inhaler, you can give them a Foster. And everything that I talk about today, whether it's MDI or Nexthaler, which is this one, the dry powder inhaler, is exactly the same. So you only have to remember it once. So that's the MART regime there. Again, it is a great regime. You know, you can give them 2, say, you know, use one as your blue inhaler, use one as your normal maintenance therapy, and it just gets them off using those blue inhalers, which is ultimately what we want. Price-wise as well, we are exactly the same price whether you use Nexthaler or MDI. So actually in the lower strength, so the 100/6, it's half because they're only using it once in the morning, once in the evening. Medium and high dose are exactly the same. Just to note, you know, a quick note with some of the other inhalers, if you use it in high strength, it does double the cost. So that's quite important. Now, I mentioned earlier about, you know, not one device suits all patients, and we know this. So having the right device choice for the right patient is really important, and this is where the Foster Nexthaler comes in. So it's a really unique device. It's 120 doses per inhaler. Dose counter counts down in ones. The biggest thing that makes this unique is that if you play with this inhaler, it doesn't move down. So what that means is it's only going to count successful inhalations. It's a really, really foolproof device, really easy to use. You literally open, suck it in, there's an audible click, which means they've reached the correct flow rate, close it, dose counter goes down. So it's literally like this. We get them to hold their breath for about 10 seconds, close it, dose counter goes down. And like I said, it only counts successful inhalation. So if you're not able to make this click, that dose counter won't go down, and you know as clinicians that, you know, that inhaler is not suitable for that patient. So I've made it click. If I try again, nothing happens, so you have to reset it. Again, if I don't hit enough flow rate, close it, that's not going to move. So again, really foolproof, really easy to use. If you do want any placebos, you know, if you have my email addresses, or you can pop your email address on the chat function, I can follow up with you after. I can give you some placebos. We do offer a lot of other respiratory support as well, so if anybody does want anything, please do let me know. In terms of the sustainability that I mentioned, so Chiesi has actually been working in the background to sort of, you know, look at some of these carbon reduction solutions, and we are coming out with an environmentally friendly propellant. So we have been working on this, you know, since 2019. We invested a lot of money into this. So it'll be coming in 2025, and it'll bring down the carbon emissions the same as the Foster Nexthaler. So what that means is the MDI will be exactly the same as the dry powder, gets rid of that pressure to use more dry powder inhalers, and you know, it gets rid of that unnecessarily clinical switches. So if anyone does want any more information on that, there is this website, which is our Chiesi Air website. So please do have a look on there. And like I said, if you do need any materials, any support from myself, then drop it in the chat function and I'll pick it up from there.
Thanks. I'll find my presentation here. Thank you for having me. It's a pleasure to be able to talk to you. I normally see your names on the letter, but it's good to know that you really exist. I want to do a quick run and do 2 things. Tell you a little bit about the hand unit at the Royal Derby Hospital, and then do a little run about the management of elective hand conditions in general practice, and when to refer, which is something that sort of keeps evolving. The unit is called the Pulvertaft hand unit after Guy Pulvertaft, who was a surgeon in Derby from the Second World War, and he retired about 1975. And he's the guy who established hand surgery in the UK, and the guy who started tendon surgery worldwide. When division of a flexor tendon in the 1940s was an indication for amputation of the finger, because they never did anything. So many workers ended up with amputated fingers and bits of hand. And Guy Pulvertaft started repairing them and showing good results. And the unit is named after him. We have 12 consultants just doing hands. And we have 5 fellows, which are very senior trainees just before they get their consultant post. And we have a very good team of hand therapists, which are a mixture of physios and OT, and a good team of secretaries. We don't have any really junior doctors with us. They're all quite experienced people. And when I meet people and they say, what do you do? I say, I'm a hand surgeon. They look at me like saying, well, what do you do the rest of the time? Because that's a very small thing. In fact, last year in our clinic, we saw over 14,000 new patients, over 30,000 follow-ups. So we see about 50,000 visits in our clinic. And we have 3 operating theaters. We do about 5,700 operations in our theaters, plus some other operations in the treatment room and emergency theater. So over 6,000 operations a year. So it's a reasonable size department actually within the hospital. And about half of our work is trauma, hand trauma. And what is hand trauma? Well, there's a great variety of things. It's not just what people think finger sprains. For example, this guy was a 19-year-old university student. He was involved in a car accident and abraded his forearm and went to one of the A&Es in the region, not ours, where he was assessed and radiographs was taken, the forearm was mangled, and he was offered an arm amputation. But being his right dominant arm, he was studying architecture at university. He said, no, thank you very much. I'll go somewhere else. So he came to see us. This was fixed, flapped. We rerouted his tendons. And 2 months later, he was back at university with a very functional hand. So a lot of the severe trauma can be treated and get good results. But you need quite a specialist team to do that. Like this guy had a close encounter with a circular saw, and we can put most parts back and giving a reasonable functional hand. That's another guy in the region. He was shot at short range in the right wrist. So these blew up both arteries. So the whole hand was ischemic. And he was also shot in the other arm that went through the brachial plexus and the artery, giving an ischemic arm. So it took us all night to get both bits vascularized, but he got a very good function. So all this severe trauma from the East Midlands comes to us, not just from Derbyshire, from the really bad injuries to some of the little tricky ones. And so we spent half of our time dealing with the trauma. We spent the other half dealing with elective surgery. And we were very early adopters of day case surgery. So we try not to keep people in hospital. We try not to bring them in unless we can treat them. And over 95% of cases we do them as day case. So patient comes in, has the operation and goes home. We do the full range of hand surgery, and the demand sort of increases a little bit every year, except rheumatoid surgery, because the rheumatologists are much better at treating that. Inflammatory arthritis are going down, so we operate fewer and fewer rheumatoid patients every year. And also the big industrial accidents we used to get, that doesn't happen very much these days because health and safety is so strict at the big companies that have nearly abolished that. So that practice has changed. So the common conditions you will see the common conditions that we end up seeing, and these are our 5 top diagnoses on the elective side. Those are the things that keep us busy. Carpal tunnel syndrome is something that you will see a lot. People come to you with pins and needles, pain in the hand, worse at night, wakes them up. They may have muscle wasting. They may have a positive Tinel-Phelan's test. You'll remember that the median nerve goes from the forearm into the hand through the carpal tunnel. And at the carpal tunnel, there are 1 FDP and 1 ABS tendon for every finger, and 1 FPL to the thumb. So 9 tendons and nerve. And if the pressure increases, the one that suffers is the nerve and gives you all these symptoms. And in some cases, it can be very painful. Just remember that the median nerve goes through 3.5 fingers. The problem is that patients often don't read the book and they'll tell you that all the fingers are numb, or they don't know exactly what the numbness is. So the history they give you is very variable. So it doesn't really adjust to the description. But somebody that comes with pain, altered sensation, which is worse at night than during the day, most likely diagnosis is the carpal tunnel. Penal test, we do it percuting on the carpal tunnel. And then if that does anything to it, yeah, that makes it tingle. That shows you the place of compression quite often. And where we do the Pelham test, it just bends the wrist. That increases the pressure in the carpal tunnel and precipitate the pins and needles of the numbness in the thumb, index, middle, and sometimes ring. If you want to test the power, the best one is the abductor pollicis brevis. And the way I do it is put my finger there and say, just bring the thumb to my finger and push against me and see if compared to the other side, they've lost any power or not. So it's a clinical diagnosis. It's a syndrome, group of signs and symptoms. And nerve conduction studies is not a great test for carpal tunnel for several reasons. One of them is that you only test large fiber in the nerve while the pain is conducted by small fibers, and it only tells you if the fiber is damaged. If the fiber is irritated, it doesn't tell you anything. But carpal tunnel is very common. There's several studies where its incidence is reported between 1 and 15% of the population, depending on how you diagnose it, but probably about 5% of people have a degree of pins and needles that can be attributed to carpal tunnel. And of course, diabetic people get more of everything, rheumatoid, hypothyroid. Pregnancy, they get it temporarily. So if you can just jolly them along, they may resolve themselves. And patients on dialysis, renal patients get it. And they say that the incidence is increasing. Probably the level of diagnosis is increasing. It's been around a long time. We only get nerve conduction studies if we want to rule out other things, usually. For example, if they've got neck pain, neck stiffness, could be a cervical radiculopathy, or they may have a neuropathy, or they're diabetic, then we'll get nerve conduction studies to prove that we've got the right diagnosis. So what can you do for it? Modification of working practice is something that is always mentioned, but it's difficult to apply, really. Splints are very useful, particularly for people who get predominantly night symptoms. You give them a splint at night, they'll sleep better, but it doesn't get rid of the problem. It just makes it more manageable. A steroid injection at the mouth of the carpal tunnel. And I put at the mouth of the carpal tunnel because you don't need to inject into the carpal tunnel. If you have a tight carpal tunnel and you inject inside, you put more fluid, you're going to increase the pressure, make their symptoms worse. So just put it just before the carpal tunnel. And it says a steroid injection. Many people, many pathways will say steroid injection and local anesthetic. There is no need to inject local anesthetic. It is not a painful injection. And if I inject local anesthetic in my patients, I just make the whole hand numb. And then they have to go back driving with a numb hand, which is not great. So I don't think it has an advantage in injecting local anesthetic. Just steroid is fine. People have tried absolutely everything for carpal tunnel, from non-steroidals to diuretics, physiotherapy, ultrasound, yoga, you name it, acupuncture. But there is very little evidence for anything else other than the splint, steroid injections, and of course surgery, which is what we do. We do about 1,000 carpal tunnel releases for this every year in Derby. And it just means coming to hospital, have a bit of local anesthetic, where we put in the injection, we incise the skin, divide the retinaculum, make sure there's nothing wrong in the nerve, and put some stitches, give them a bandage, send them home. And if you look at the results down the line, 2/3 of patients will tell you that they are completely cured. About 1 in 4, they are much, much better, but they occasionally get pins and needles, or they have some numbness that persists. Numbness can take a very long time to recover. And about 5% of them still have symptoms, or they don't feel that things are much improved, it's usually not a problem with the technique of the operation. It's usually a problem with the diagnosis. If they have a neuropathy that's quite dense and the main problem is numbness, that's not going to improve. Or if the problem is somewhere else, like cervical radiculopathy or thoracic outlet syndrome or generalized neuropathy, we may not do very much good. So getting the diagnosis right is important. And here's where the injection sometimes helps, because if you put an injection in the carpal tunnel and that's improved, you can be reasonably confident that that's where the problem is.
Carlos, can I just ask
Yes.
something? Sorry.
Yes.
It was just about when you talked about testing, the Tinnell's and Felon's test.
Yeah.
If their history is really suggestive, but you do the test and it doesn't elicit much,
Yes.
would you still say it's okay to think it, probably is carpal tunnel if the history is really good? Or how, how accurate do you find those tests?
We've looked at the accuracy of the clinical test, and the answer is they're not very accurate.
Okay.
And you can fully diagnose it with your history, and the history they give you is much more accurate than the test. And in fact, in some places they've stopped doing the test at all. And that has one advantage actually, and is that if you do consultations online, you can get the history and diagnose them with the same accuracy that if you see them face to face.
That's really interesting. Okay, so if the history is really suggestive, that's the thing to go on. Yeah. Okay.
Yeah. And I mean, it's good to do the test. It assures you that you're not missing anything. But the history is what tells you the truth. And in some places they use questionnaires, the Boston questionnaire, and that gives you an idea of the diagnosis and the severity of it. And that correlates well with nerve conduction studies and outcomes of treatment. So history is the key thing.
Okay, thank you.
Yeah. I'm going to digress a bit, and there is a rare disease which is TTR amyloidosis. There is a protein in plasma called transthyretin. It's a transport protein. It transports thyroid hormones and vitamin A, and this can hold and cause fibers of amyloid that deposit in the tissues, particularly in the heart. The reason I'm telling you this is because at the moment we're running a study I'm very interested in. It was noticed that many people develop heart failure and they go for cardiac investigations, and they've had the carpal tunnel release between 5 and 10 years before. So what we're doing is when we do the carpal tunnel, biopsy them and see if we find some of these amyloid that in the future can cause heart failure. And we're finding that that's quite a high pickup rate actually. So all we do is do the carpal tunnel normally, take a little bit of biopsy or retinaculum. And I'm mentioning it because some of you patients may ask you about it. If they are positive, then we'll offer them some cardiac screening, ECG, echocardiogram, and then depending on that, they may get more investigations. And we'll see if we can prevent them from going into heart failure by diagnosing them very early. So it's not really heart surgery, it's more cardiology, but I'm just a technician doing the biopsies. And you may have patients that come and tell you, and they said, oh, they want me to have my heart test after having carpal tunnel. That's what it is. It's just research at the moment, but it looks very promising. So you'll be more familiar with this than I am. That's the Derby and Derbyshire Integrated Care Board. What they think is that you should try physiotherapy, neutral wrist splints, or an steroid injection. Really, for physiotherapy, there isn't all that much evidence that sorts it out. But splints help the symptoms at night, and an injection settles it, usually for a while. It often comes back, but it's a good diagnostic test. If they are very severe, or they score high on the Boston questionnaire, or they are in a lot of pain, carpal tunnel can be very painful, then going for surgery could be the best thing. And if somebody is very bad, give us a call and we'll see them soon, because it can be quite debilitating. I'm going to move to ganglions. You've all had people coming to you because they got a lump on the wrist or the hand. The commonest ones are the dorsal wrist, can be the follow wrist, and on the fingers. That's the typical appearance of it. They bend the wrist and become more obvious. And that just a fluid from the joint that's pop out. It's really a pseudocyst. It's fluid that pops out. Now, if you really go looking for it, you'll find ganglions in 50% of adults, and they're not painful. Ganglion itself is not painful. It's only painful if it's associated to ligament degeneration, or it presses on a nerve, or it's in a tight space. So if it's painful, you need to wonder, well, is it really the ganglion or not? And they transilluminate. They're fairly typical. I don't think they're difficult to diagnose. If they get very painful or they cause a problem, we can excise them, or we can aspirate them, or we can leave them alone. Problem with aspirate them is that they often are loculated like this. So that's a ganglion excised from a follow wrist. You can see it's a bit like a blackberry in that it's got several cavities. So you put the needle in there, it's difficult to empty them all. You'll empty one or two. So sometimes you put the needle in, you're in, but even then, it doesn't go down. So what do? We try hard to convince the patients not to do anything. And I know you do as well, and you're very successful at that, because the number of referrals we had for Ganglion has been going down for years. If they are worried about it, and they may not tell you unless you ask them, as many people think, oh, well, it could be cancer, or, I had a breast lump and now I've got this and I don't like it. If you aspirate them and show them the fluid, they're very reassured by that and usually happy to leave it alone, even if it's come back. Or you could have an operation. The old treatment was hit it with the Bible. Not very recommended. It just gives you a bruise, and even if you get the ganglion down, more often than not, it comes back. But aspirated is something that, if you're happy, you could do it in the GP practice. What we tend to do is put a little bit of local under the skin first, because to aspirate them, the ganglion, you need quite a thick needle. You need like the wide needle kind of thing, or a small Memflon, because its consistency of toothpaste is quite thick. So it's kind to put a bit of local anesthetic first, give it 10 minutes, and then put a needle and see if you can empty it, and that will reassure them. We did a study, that's a good number of years ago, but basically, if we did nothing and left them alone, about 50% of ganglions disappear. They may take a long time, take years, but in the end go. Well, if we aspirate them and we follow them up for 5 years, about 60% of them make another one, maybe the same ganglion or another. And if we operated on them, even then about 30% make another one. And sometimes it may not be the same ganglion, but they had a ganglion, they have another one. Two things to be aware. One is the lump on the back of the wrist that moves when you move the fingers. And that means that lump is associated to the extensor tendons. So you can see this lady that has a lump here that was diagnosed as a ganglion, but when she makes a fist, the extensor tendon move distally and the lump disappears. Yeah, so that's not a ganglion, that's extensor synovitis. If it's a ganglion, you can move the fingers up and down, the ganglion doesn't move. The other thing that's worrying is the lump that's quite large. This guy had been to see his GP 3 times and had actually been to an orthopedic clinic, and everybody told him to leave the ganglion alone. Eventually, pushed by his wife, he came to see me. This did not transilluminate. That was a solid lump, and there was a synovial sarcoma. So just be careful with that. The general rule applies. Any lump that's more than 5 centimeters is a sarcoma till proven otherwise. Yeah. So don't miss those ones. And then there is the mucous cyst. It is the one on the dorsum of the DIP of the finger, associated to osteoarthritis. And this can cause 2 problems. One of them is that it can discharge. And if it keeps discharging, sometimes it stays open. And the problem is that the the joint is very close to there. So if you get an infection there, you can get the septic arthritis very quickly, and then that becomes a very big deal. The other problem is that it presses on the nail matrix, which is underneath there, and deforms the nail. The nails get grooved, and people don't like that. So what we tend to do is explain to people that this is a ganglion, and if they can leave it alone, we tend not to aspirate them because of the risk of infection. You could argue that. And if it causes problems or if it's troublesome, we offer them an excision and we just go and take it out, put a couple of stitches, which we can do under local anesthetic. So what do pathways say about ganglions? Well, they said if you can leave them alone, if aspiration fails or the ganglion persists, then, or it's causing a nail deformity, then it's reasonable to excise them. But as I say, this is one of the things that we've done fewer and fewer over the years. Next thing that you'll see is trigger finger. People that come because the finger catches or gets a stacking flexion or is painful. What causes this is that the flexor tendons go into the hand, and then from the palmar crease in the hand to the fingertip, they live in a tunnel made by the pulleys. And if the tendon gets a bit swollen, as it gets into the tunnel, it catches, and then every time goes in and out, catches, and that's more swollen and ends up not running and getting the finger stuck. And that can be quite painful as well, causes synovitis that is sore. So the patient will tell you that it locks in flexion, sometimes worse first thing in the morning as well. The finger feels slow or stiff, and it's difficult in making a grip or holding things in the hand. Will be turned over the pulley, and they often have a palpal note, and they can demonstrate how the finger triggers. You can treat them with a splint, but my view is that very rarely resolves the problem. A steroid injection at the tendon sheath works very well, and it settles over 70% of patients. Necessary can be repeated. Surgery under local anesthetic is very successful. What we do there is make a little incision, find the tendon sheath, which is there. That's we call it the A1 pulley, and divide that longitudinally so the tendon can run up and down. Have a look at the tendon, which is that. Make sure there's nothing wrong with it. Just put a couple of stitches. So that works very well in cases where the injection of steroids has not resolved it. Again, what do pathways say? Try to treat them conservatively. Try 1 or 2 steroid injections or a splinting in the affected finger. If that fails, then offer the patient a surgical release. If the finger is permanently locked in the palm, you could consider surgery. I've seen people like that come with the finger that's been stuck for a while, but it's because it's too painful. If I put some local anesthetic, leave them for 20 minutes and then come back and push the finger straight, they sometimes get going, actually. So I would try that again before I offer them surgery. If the patient has a history of unsuccessful injections in several fingers, then they develop another trigger finger, it's unlikely that the injection is going to help. And they'll tell you that they just before they go ahead with the operation. There is some issues about steroid injections in diabetics, and diabetics as well get worse trigger fingers that tend to recur. So probably we should have a lower threshold to offer surgery to diabetic patients with bad trigger fingers, because the result of the injection is not so good and the risks are higher. The other group you will see is people with Dupuytren's contraction. Your skin all over your body is very mobile, except the palm of your hands and the sole of your feet. And that's a good thing, because if the skin was wobbling in the palm of your hand, you couldn't hold things firmly. Or if it was wobbling under your feet, you'll not be very steady. And the reason why the skin in the palm of the hand and the sole of the feet doesn't wobble is because it's got this 3D fibrous structure, which is the palmar fascia or the plantar fascia. And the palmar fascia has longitudinal fibers, transverse fibers, and vertical fibers, and that steady the tissues. So these fibers, this tissue, start making like the scar tissue, basically, histologically. You need to have the genes for this. It's a genetic disease, but not everybody who's got the genes gets it. It appears much more in men than women, and it appears much more in older people. So the older you get, the higher the risk of developing this. And what we do with people is see if they can put their hand flat. That's the tabletop test. I'll show you this. And the recommendation is to refer them if it's progressing quickly or if the proximal interphalangeal joint is contracted. So this patient I saw yesterday, which is unusual actually, because I don't usually see them, but she found her way in, and she came with a painful lump in the hand, which is there, and you can see that that's what she's saying. She found that that was painful, and the vertical fibers are contracting and they're pulling the skin in, make like these dimples, and that's a Dupuytren's nodule. Affects most commonly the ring of the little finger, can affect any finger, but she didn't have a contraction. So I said, right, can you put your hand flat on the table? She said, yes, I can do that. So that's not causing a contraction. So all she needs is reassurance and say, look, you know, his Dupuytren's, he may turn up into contraction, he may not. All you need to do is watch it. Every Sunday, put the hand flat on the table. If you find that there is a space between the hand and the table, you cannot flatten, come back and have a long chat about it. But we try very hard not to do anything to those. So what are the options for treatment? Well, observation, reassure the patient, explain the nature of it. It's nothing bad, it's not cancer, it's not going to do anything drastic, just keep an eye on it. The other thing we can do is cut the course of Dupuytren with a little needle. I put injection of collagenase in grade because we don't have it available, and surgery. So this is the case of a Dupuytren's. You can see the significant contraction at the PIP, and you can just see the core there of Dupuytren's. That's what generates the contraction. We can put a little bit of local anesthetic here, put a needle, and just move the needle side to side, like if it was a mini knife, and cut that cord, give it a push, and we can do that for several fingers. So put a bit of local anesthetic, get the needle, a blue or a green needle, and just cut the cord physically under the local anesthetic. Takes about 10 minutes to do, and then you give the fingers a push, and they straighten and just get them moving. So this is minimally invasive, really. You know, they're back playing golf the following week, and the results are reasonable, although the recurrence rate is significant at 3 and 5 years. Collagenase is an interesting substance. It's an enzyme produced by Clostridium histolyticum. And the idea is that you inject the cord, and that enzyme cuts the collagen and breaks the cord. So what we did is inject it in the cord and then leave it for 48 hours, see the patient again, give the patient a push in the finger, and that breaks the contraction. And we actually did the European studies in Derby for collagenase to get its approval for this, and that went well, and we've done a lot of research on this in the last about 15 years. Then what happened is that cosmetic surgeons found that this works for people that have got this pale orange, you know, like orange skin, cellulite, from the buttocks and the thighs. You inject this, and that makes the skin goes nice and smooth. And the companies decided to use all their production for the cosmetics, who pay much more than we do. So now that we've proven that this works, we don't have it available for hand surgeons, fortunately. So that's off the market for now. And then the other option we have is open surgery. So we do a zigzag incision, take the cords out, stitch it up, takes about 2 weeks to heal, It takes about 4 weeks for the patient to settle. This has a better result long-term. Recurrence is less, but of course, this is a more invasive procedure. So what do the pathways say about Dupuytren's? Say if the contracture is moderate, so less than 30 degrees at the metacarpophalangeal joint or less than 20 degrees at the proximal and temporophalangeal joint, try to reassure the patient and leave it alone. If it's more than that, offer them an intervention. And the intervention can be nowadays needle fasciotomy or form of fasciectomy, which is excision of the cord, and there are several. And we go through the details of the several options. Some of them are a bit more invasive and have a better long-term result. So in younger patients, we'll use more invasive surgery. In older patients, we'll do minimal surgery, and the recurrence is less. And finally, the last condition I want to run past is osteoarthritis, which is something you know a lot. All of you see patients with osteoarthritis. And osteoarthritis at the base of the thumb is quite common. The thumb is 50% of the function of the hand because it's the digit that can oppose the other ones. And osteoarthritis at the CMC joint is very common. And our referrals have doubled in the last 10 years, probably because you guys are diagnosing it more. And one interesting thing about the thumb is that as you pinch, for example, if I go and use my key to open a lock, I'll generate about 7 kilos pinch force. But because of all these muscles acting on my thumb, the force multiplies at every joint as it goes down. And the force around here is about 10 times what I'm generating here. So every time I open the lock with a key, I'm generating about 70 kilos at the base of my thumb, which is a joint that's about 2 square centimeters in surface. So it's huge pressures. So it's not surprising that this joint gets a lot of wear. So what can you do about that? Well, there are 3 things that help. One is modification of lifestyle, and that's easier said than done, to be honest. Physiotherapy does help. Doing the right exercises makes the muscles control better the joint, and if you have better control, you have less instability and less pain. The splints is something that we have used a lot, and we've been involved in a bigger study in recent years, which shows that beyond patient education and activity modification, splints help little, to be honest. So the patients liked it, but it did not decrease the pain or made them more functional very much. So we're using fewer splints probably. A steroid injection in the CMC joint of the thumb works for a while, which is variable, and the injections work less well as you repeat them. So the first one will work for 9 months, and then the second one will work for 5 months, and then the third one will work for 2 months, and then they say, well, need to do something else. We tend to do our injections under X-ray control just because we've got an X-ray machine in our patients in our clinic, and you can see how you mistake the joint and exactly where you're injecting. It is also a good diagnostic test for us because if you put the injection at the CMC joint and that abolishes the pain for a few months, at least you know that the pain is coming from there. The rheumatologists do the injections and the ultrasound control, which is good, that's fine. If I'm doing a peripheral clinic and haven't got an X-ray machine, I'll just do it blindly, and that's fine as well. If you know how to do it, I don't think that's too much of a problem. But it is important to get the steroid in the joint for 2 reasons. 1, it works better. And 2, if you put it superficial, you can cause the pigmentation and atrophy of the skin. And that's quite a visible part of the hand, so people quite resent that. So you need to be a little bit careful, but it is a good treatment. Does it work? Well, interestingly, in the early stages of osteoarthritis, it works quite well, maybe because most of the pain is because of synovitis. As the arthritis is more severe, it works less well. And people with very advanced osteoarthritis hardly benefit from that. So what can you do after that? Well, once they've tried activity modification, splints and injections, the next thing is surgery, and there is a whole list of operations for that. The classical one is excision arthroplasty, which is a trapeziectomy. It involves taking out the trapezium, throwing it in the bin, and we usually make a little support for the metacarpal of the thumb with some tendon. You can do joint replacements. Arthrolysis is fusing the joint. That's not an operation I like very much because you lose movement of the thumb, and we fuse it in one position that for some tasks is really not good. So I think it limits function more. Denervation is an operation where we cut the little nerve that go to the joint, and that has benefit in two ways actually. One of them is that you interrupting the pain signal from the joint to the brain, so it's less painful. But also, inflammation is a complex problem that needs nerve input. So if you disconnect the nerve, inflammation gets less. To the point that if you have a completely denervated joint, and then you get an inflammatory disease like rheumatoid arthritis, you don't get rheumatoid arthritis in the denervated joint. It's just one of these little curiosities. And you can do osteotomies, which means realigning the bone here. So classical thing would be do an operation, usually do it on the regional block. So we put an injection at the top of the arm, so we can use a tourniquet, make a small incision, take the trapezium out, and then use a bit of tendon to stabilize the base of the metacarpal so the thumb feels strong. It's a good operation, but it takes time to settle actually. It takes patients 3 or 4 months before they're happy they had it done. It grumbles for a while, but then the longer it goes, the better it gets. Another option is to do joint replacement, and this is the one we are using nowadays. And it's a bit like a mini hip replacement. So it's got the stem, like the femoral stem that goes into the metacarpal. It's got a neck with several lengths. And then this is a double mobility. So it's got a metal ball into plastic ball. And then on the other side, there is a socket. So the plastic ball goes into the socket. And I'm very impressed how happy people are with this. That's several things. It settles very quickly in that we do the operation, pain is gone. They have a fantastic mobility. And because it returns the length of the thumb, the whole thumb realigns better and they're more powerful. So for certain people, we'll talk about it. It's got possible long-term risks, but at the moment they're doing very well. So that's most of what I wanted to cover, which is the elective conditions that you will see. I prefer to leave time for questions than me rambling on. But one thing I wanted to mention is that we have a very expert team in the hand clinic. This is Sheila at the desk in the hand clinic, and there'll be a nurse in charge every day, and they've all been in the unit over 20 years, and they will be a consultant in clinic. So if you come across something that you think it's an emergency or an issue that you want to discuss, you want some advice, just give us a call, and Sheila will answer the phone, and if she needs to ask one of us is responsible for the clinic, and we'll be very happy to talk to you. Thank you very much. Thanks for your attention.
I can see we've got a question. Shall I just read them out to you? Is that all right?
Yeah, yes, please. You edit them, yeah.
Brilliant. So Wallace said, regarding the use of splint for carpal tunnel syndrome, is it right to advise the patient to wear them during sleep? And for how long should they try using the splint / conservative management before deciding to refer?
Yes, you can. What we tell them is to use the splint at night. The splint has to keep the wrist straight, yeah, because that's the maximum capacity of the carpal tunnel. Normally, the commercial wrist come with a bit bent like that. So you've got a bar in the middle, so just to straighten it for them, if they're there, or you've got them in the practice, and that will give the nerve a rest overnight. While they use them, they'll sleep better. Usually when they stop using them, the symptoms will come back. and they don't need something else. The only exception is pregnant women or after delivery. They can get carpal tunnel for a while, and if they can tolerate the splint for a period, they may get away with it. So in most people, it's just managing the symptoms. And then sometimes carpal tunnel oscillates. They have better periods than others, but the trend is to get worse. So sooner or later, they'll come back to you and they say, well, this is worse. I'm fed up with it. I need something else. And then it's the time to discuss injection versus being referred for surgery.
Okay, no, that's really useful. And actually on that topic of splints, Rebecca's just asked, splints for thumb OA and carpal tunnel, do patients have to buy their own? And she's just putting in brackets, we can't prescribe in terms of GP.
Well, if they come to our department, we'll give them to them.
Yeah.
Most people just buy them off the chemist or whatever. The problem is that a splint needs to fit well. Otherwise, it's very uncomfortable. I mean, that doesn't work very well. Or the ones in the thumb splints often work because they're not allowing you to use your thumb. And then, of course, it's not so painful, but they cannot do anything with it. So that's been very cumbersome. So if you have somebody who's got a particular problem, you can refer directly to our therapists, and they'll see them and they'll make a custom-made splint for them. And that's sometimes the case when people have a lot of pain, but they don't want an operation or they are too high risk for an operation. And our therapists will assess them and make a custom splint, thermoplastic or whatever. And those are much better tolerated and more effective. My therapists often say that splint who fits everybody fits nobody. And I think they're right, actually.
Yes, that sounds very wise. So that's interesting that you can get them custom made if people don't want operations. And so I guess patients can probably buy them off things like Amazon, but you would say if they can go to a pharmacy and get fitted, that's probably better. Yes,
that if it's somebody who can mold them a bit for them and make sure it's the right type of thing, that helps a lot.
Yeah, well, that's really useful.
I've seen patients coming to clinic because the splint doesn't help, and then have a look at it, and they're wearing a right one on the left hand, or they're wearing upside down. So, well, I'm not too surprised, If you have a look at the instructions, what instructions, they usually come with a little pamphlet, but nobody reads that.
Brilliant. Sophie's asked, she's just said, apologies, I may have missed this, but post trigger finger injection, do you recommend buddy strapping to splint the treated finger at night, and how long for?
I usually don't. I just say, look, just do whatever is comfortable. And sometimes they get a bit of a flare after the steroid injection, and it's quite sore for a day or two. It's sometimes very sore. They think they got a bad infection or something. They got a flare because of the steroid. And I just let them do whatever is comfortable. I tell them ask them to take some painkillers, whatever suits them for the next 24 hours, and then see how it goes. But then just let them move, and the sooner they move, the better, really.
Fine. So you don't really buddy strap. You just let them do whatever.
No, just whatever is comfortable. Yeah, whatever you want. Just on the basis that you're not going to do any damage. If it's more comfortable, do it. But what I want them doing is getting moving as soon as they can, quite freely.
Yeah. Okay. Brilliant. So movement's important there. Marzena Whitaker's just asked. Injury to nerve by putting cannula in dorsum of hand with numbness and weakness in 2 to 3 fingers lasting for 3 weeks and ongoing. What would be treatment? So I presume she's seen a patient who's injured their hand by putting in a cannula in the dorsum of their hand with numbness and weakness in 2 to 3 fingers lasting for 3 weeks and ongoing. Yeah, what would be the treatment there?
Okay, so the problem there usually is that a sensory nerve gets injured, and that happens a lot, particularly when the cannula is put on the radial side of the wrist. There's a nice big vein, juicy vein there, and that's the one you see. You put it there and you hit the radial nerve or a branch, and that is very painful. That causes an neuroma of the nerve, and then the pain is what inhibits the movement. They don't like moving it. They feel weak because of that. And what we need to do, we need to see them. because first we need to manage it, and sometimes take the neuroma off, or at least put some local anesthetic test to find out where the neuroma is, block the pain so they can't get moving. Otherwise, they're going to make a neuroma with a lot of scar around it. And then they develop this so-called CRPS and all this business. And that also generates a lot of complaints and paperwork. So from our point of view, if there is a cannula injury or an extravasation, you put an injection and you think the injection needs to go in the vein, but it's gone outside or whatever, we are quite happy to see them at short notice. And if you ring us, we'll see them in the clinic and we'll assess them. And that then prevents a lot of trouble down the line.
Okay. And what kind of speed would you want a referral like that?
Just ring us.
Ring us. Okay, yeah. Perfect.
But because otherwise, if you write to us, the system just doesn't work. I mean, I'm sure that's not a surprise to you. It just goes onto a pile and then sits there till somebody goes and stays a big pile, you know.
Okay.
Nobody even reads it. So if there's an issue like that, send us an email or bring us in the clinic and say, look, I've had this. Or the other typical thing is somebody's injecting a carpal tunnel or in the practice and you feel that they have a lot of pain. You say, oh, maybe I've injected the nerve, or you worry. Give us a call. We'll see the patient quickly, assess them, and the sooner we sort that out, the better.
That's so useful. I actually called, because I'd heard you speak, I called maybe 6 months ago about an odd case and they were seen same day. So thank you. Yeah. Yes, it did work.
we have acute clinics every morning and every afternoon. And we're there, you know. And,
yeah. That's such a great service, isn't it? Sorry, Wala's asked, I see many patients with a diagnosis of de Quervain tenosynovitis proven on ultrasound. Could you give us a quick overview of the management, please?
Yes. So the Quervain is an entrapment of the first extensor compartment. So there are two tendons there, APL and EPB, and they're very painful. Commoner in young mums. And in certain groups of manual workers. The young moms is usually after the first baby, and we think it's because they hold the baby too tight because they're worried about dropping it. The second baby, you don't love him so much, so you don't hold him too tight and you don't get it. And then for the Quervains, there are three things that help. A splint helps, but of course that immobilizes the thumb to some extent and is cumbersome. Putting an injection of local anesthetic and steroid helps. Again, be very careful with extravasation. And the third thing is doing a little operation. So I usually offer them a steroid injection. And the way I do it is not mix the local anesthetic and the steroid. So have two syringes, put a little bit of local anesthetic. And when I know that it's inside the compartment, it's not lifting a blood, then I keep the needle there, change it, put the steroid, and inject about 20 milligrams of Kenlock or something like that. And that's very successful. Again, one injection settles about 75% of them. But if you guys think it's helpful, we'll do them again. I quite like meeting the GPs, actually. It's fascinating to see the face, you know, when you've seen the name so many times. But yeah, I think we should do them again because we've not done it for 4 years now, probably.
That's so kind. Well, thank you so much for, as I said, being with us, Carlos, and going through that. Thank you, everyone, so much for joining tonight. It's really great to have so many of you here. And as I said, on Monday, we'll be going through learning disabilities, and it should be a really, really good session. We've got their team, the learning disability team, coming to speak to us just about all the things that it would just be so helpful to know a little bit more about. So what their team do, when we should be referring to them, how to do a good yearly physical assessment with people with learning disabilities. So yeah, should be really, really good.